And then we do I think this is set up right. Usually, yeah, it's a really large room for, the biggest class I feel like is 30 students. It's a lot. It's got a really nice, the whole podium thing is set up super nice for all the Zoom things that I might use it for.
Yeah. And I do like this.
Mhm.
Okay, great. How many students do you have?
20 something?
Oh.
Yeah.
Are they in person or
Sorry,
are they Zoom and in person or
just in person. And the quarter blues is real. I think we're all feeling it. So close to summer, but not there yet. Let's see. Well, that seems like that's correct.
So since I'm teaching you all today, I'm gonna request that you move down. So if everyone can move down, that would be great. I can't see very far. I mean, I can, but the first 3 rows. Yeah, like everybody move down. That would be great. Like for the front half. Dr. Lynn wouldn't make me do that, but I will. Thank you.
Do you want the camera on with the base camera on, or does it matter? Not really. Okay. I'm pretty sure they can see this now.
Okay.
So just
Thank you. Classes
oh no.
at my brother's house. And so these are progressive. So I can see forward, but then it gets blurry.
Oh yeah.
Like my other classes are progressive and they're much they're fitted better.
For distance and close.
Yeah.
Yeah.
But these are in the fit is not that good.
So pretty sure this is all right. Just see if Jamie sent me an email. So no email. I think that's a good sign. She sent me an email last time saying, "Are you still getting set up?" It's like 20 minutes later, and it's like, "Oops, I just did everything wrong." Okay. I think we're good. You need my clicker?
Yeah.
Cool. Yeah, just forward, back, and then laser in the middle.
Okay. Cool. Right. Forward, back, and laser. Okay. All right.
Turn whatever you want to do, whatever you need to do. All right. Well, thanks everyone for being here on our week 8 or 9 or wherever week 9, wherever we are. I'm really thrilled to have Dr. Molina here with us today to share her expertise in the realm of public health, So she's going to be approaching some of the similar topics I've been dancing around, but she'll have better answers for you than I will. So I'm excited to have her share with you.
Thank you, everyone. Thank you, Dr. Lim. Here, I might turn this a little bit. Okay, so I come to this class, I think I've been coming to this class every year for maybe the past 4, like, I think we've been doing this since the pandemic or even before. Yeah, so this is one of my favorite lectures to give, because I get to talk about something I love, which is public health, within the context of something that I'm not really entirely familiar with, right? Neuroscience, to all of you who have much more background in neuro than I do. But I also love it because I tend to have students who are curious about public health. How many of you taken a public health class? A few, right? We've got some public health minor students in here, but so that's again why I really truly love coming and sharing all of this with you. Today I will be talking about a public health approach to, again, substance use, or the topic that you've been talking about all quarter. Okay, great, thank you. So today's lecture, pretty straightforward. I'll share some substance use data to kind of set the groundwork for what I'm going to talk to you about today. Then we will talk about public health, what it is, and then tie it all together with public health interventions, specifically for substance use. Okay. A little bit about myself. I am an assistant professor in the Department of Health Sciences here. This is my 8th or 9th year here at DePaul. I teach in the Department of Health Sciences courses specifically in public health. My background is also in gerontology. Dr. Lim comes to my aging class every autumn and talks about the aging brain. I also teach classes in epidemiology. I got my master's in public health from the UIC School of Public Health here in Chicago. And then I got my doctorate in public health at the UCLA Fielding School of Public Health. I have a really cute dog that I love so much, that I always share pictures of. So that's Kaya. Okay. So what I'm going to do is I'm going to talk about, again, just share some data with you all. And some of I'm not sure. You may have seen some of this data already, but I like to, again, set the groundwork for really, like, you know, in public health, we ask, what is the problem, or what is the health issue? And so I'm really going to set the groundwork for that. And starting with just blanket, the number of people. So all of this data that I'm going to be showing you is from either the Substance Abuse Mental Health Services Agency, which is a federal agency under the Department of Health and Human Services. It's either from SAMHSA, CDC, NIH. But a lot of the data that I'm going to show you is for 12 and over. Okay, and that's a lot, that's predominantly how the data is reported. In general, we have seen an increase in the number of people age 12 or over who meet the applicable diagnosis, according to the DSM-5, of having a substance use disorder. That's an increase from this data from 2021. So we roughly see about 48.5 million people. And that, again, is an increase from 46.3 million people just 2 years ago, or 2 years prior to this data. What we have seen, though, is a decrease in the number of people who are age 12 and older who have misused opioids. So a small decrease. So 8.9 million people now, are the most current data from 2023, and that's a decrease from 9.2 million. Of that age group who misuses opioids, The highest percentage of people who misuse opioids are actually adults between like adults that are age 26 and over. And we'll see in this data that even though we report the data for 12 and over, we tend to see substance use in the older adult or in older populations, not quite 12. And then with regards to illicit drug use, we have seen a pretty dramatic increase. In 2021, roughly 61.2 million people over the age of 12 reported illicit drug use in the past year. That number has jumped to 70.5 million. Okay, and so now these slides that I'm going to be showing you are tables and graphs to again really highlight what the issue or the problem is around substance use. So this is past month substance use. So that's how it's reported. Anybody who reported using a substance in the past month, these are among people aged 12 and over for 2023. As you see, the highest substance type is alcohol, followed by tobacco products, and then tobacco products and nicotine vaping are separated out. Okay. Now, please note that these are not mutually exclusive categories. So somebody can report that they use alcohol as well as vape. Okay. With regards to specifically tobacco product use for nicotine vaping, roughly 22.7% of the population 12 and over have reported past month use of tobacco product or nicotine vaping. And then if you look specifically at the different types, cigarette use is still the highest at almost 39 million. And then nicotine vaping is second. Okay. Questions or thoughts? Alrighty. With regards to past month tobacco product use or nicotine vaping by race or ethnicity, we do see that the largest, so this is the total, this darker bar up here, we do see that the highest, the group with the highest number is Native, Hawaiian, and Alaska, American Indian and Alaska Natives. I'm sorry, non-Hispanic white, American Indian and Alaska Natives. And then after we have the multiracial group, the lowest reported is Asian. Does anybody have thoughts about this right here? The non-Hispanic, American Indian, Alaska Native group has the highest rates of nicotine vaping. And actually, we'll see that they have the highest rates of a lot of substance uses. Any thoughts? Yeah.
Just wondering if that data set takes into account that tobacco is supposed to be sacred for multiple American Indian communities or Native American communities.
Possibly, I don't know. These are individuals that are reporting the use. So I'm not exactly sure if there has been much further investigation as to the why for individual usage, right? But you're talking about a potential cultural explanation. Good. Anyone else? Yes. Okay, so you said that with these communities, there's a lack of interventions. Possibly. Good. What do you mean by these communities? Okay, so what we tend to see in a lot of diverse populations, but particularly with regards to substance use and Native populations, like American Indian and Alaska Native groups, the substance use rate is high. So are rates of mental health disorders. So are rates of unemployment, lack of resources, right? And so there are a lot of, there's some outreach, right? But there's a lot of acknowledgement that these populations in particular suffer disproportionately from substance use because of, again, what we call in public health, social determinants of health. Okay, so things like, poor access to education, poor access to job opportunities, lower access to healthcare.
I guess to just, as you kind of said it, to add on, I was thinking about environmental things where there are probably more areas that are less populated per se, so again, accessibility to go to those programs is gonna be a lot.
Yeah, especially the ones that are living on reservations, right? Absolutely. So unfortunately, we do and we have continued to see high rates of substance use among this population. Like I said, there are programs, there are outreach types of opportunities, but just not enough. Interestingly enough, there are studies that show that certain cultural factors among American Indian and Alaska Native youth, those cultural factors are actually protective when it comes to substance use, particularly binge drinking. Meaning, youth who said that they had more of a cultural affinity and belonging as American Indian and Alaska Native youth tended to binge drink less, right? So if we're thinking about a type of public health intervention or behavioral intervention, we would really want to maybe highlight those that empower and uplift American Indian and Alaskan Native youth to really be proud of their cultural upbringings and backgrounds, right? So it's very, very interesting data here. Now, with regards to past month alcohol use, binge alcohol use, heavy alcohol use among individuals that are 12 and over, we see that, again, the group that I like see it and then, okay, there. Anyway, the group that is aged 12 and older, so it's, well, okay, the 12 and over is right here. And then the group that is 12 to 17 is this blue right here. This green is 18 to 25 and then 26 and over. We do see the lowest rates of alcohol use, binge alcohol use, and heavy alcohol use among the age 12 to 17, which is good. And then we see in past alcohol use that 18 to 25 have pretty high rates, but then higher rates among 26 and over. And then past alcohol use, binge alcohol use, and then heavy alcohol use is even lower. But again, we see these higher trends among these older age groups. Now, binge alcohol use is defined as drinking 5 or more for males, 4 or more for females on one occasion, right? On at least one day in the past 30 days. Heavy alcohol use would be binge drinking on the same occasion on 5 or more days in the past 30 days. Okay, which means that all heavy alcohol users are also binge drinkers. Okay. Now, with regards to illicit drug use among individuals aged 12 and over, roughly 25% of that population, 12 and over, reported illicit drug use in the past year. It's pretty high, right? Almost 1 in 4 people in the United States aged 12 and over reported illicit drug use. Now, illicit drug use is categorized. So marijuana is in the category of illicit drug use. Even though in nearly half of the states in the United States now, cannabis use, marijuana is legalized. But that is the highest number at 61.8 million, followed by hallucinogens, pain reliever, prescription pain reliever, misuse, and then cocaine. And then we have, some other types that are also reported here. Again, similarly, the illicit drug use is not mutually exclusive. So somebody could report marijuana use and cocaine use. Yes.
Just looking at like the stats and stuff.
Yeah.
So I know, like, for example, when people go to college, they're going out every weekend, so you're probably gonna see statistically higher rates with the binge, drinking, alcohol consumption, as well as the drug use.
Sure.
Do you see, like, after those ages of college, that data goes down a little bit more, or do you think it's like a reinforced, like, still kind of stays?
So that's an interesting observation and question. If we think about individuals who are using, and I think it was the first, might have been right here. So like the misuse of opioids is actually highest in 26 and over. So technically that would be, maybe post-college aged. But that's a really good question. We have to really look at the data for ages and use. But it's possible that we're seeing that. Yeah. Good question. And please, as we're going through this, if you have questions, don't hesitate to raise your hand. And so this is marijuana, past year illicit drug use or marijuana use among age 12 and over, and this is by age. And so we have the illicit drug use on this side. Again, the 12 and older, I'm sorry, the 12 to 17 category has the fewest percentage. The 18 to 25 has the highest, which kind of goes with what you're saying. And then 26 and older, which is interesting, right? Because what I just showed you was that misuse of opioids was higher in the 26 and over, right? But misuse of all illicit drug use and marijuana use is higher in this group. Right, so we see that. So yeah, potentially. Alrighty. For past year illicit drug use or marijuana use by race, again, we see the highest percentage use by American Indian and Alaskan Native. Okay, and possibly the same underlying reasons as the alcohol use. Yes.
Sorry, if you could go back one slide about the ages.
Yes.
Did they ever consider, so they're lumping all these 26 and up. Do they ever split it up by older Americans versus, just general adults?
Barely,
Rarely.
but yeah, it for the SAMHSA report that they do, it's almost like a biannual report. It's almost always reported 26 and older, like all of the graphs, all the data, and I'm not exactly sure why. I have seen some other data, like through the CDC, that breaks it up a little bit more. But for whatever reason, when we're looking at the SAMHSA data, they do it as 26 and over. And you and I know, we all know that there are huge variations between, 26 to, the highest, the oldest person alive, right? There's huge variations in, probably variations in substance use, but there's huge variations in other behaviors and demographics.
Yeah, I'm really thinking about illicit prescription opioid use for pain, right? And I'm wondering if those numbers look similar across 26 versus 80, just
Yeah.
because, like if risk taking goes down as you get older, but chronic pain incidence increases. I wonder how that balances out.
Yeah.
Yeah, it's so strange it's just 26 and up. That's like
Yeah.
a huge group.
I'll look a little bit deeper. I'll dive a little bit deeper into see if there are data that are reported. If that data is disaggregated for older ages.
Cool.
Okay. And then this is past year illicit drug use, marijuana use by, okay, we just did that. So this, I found this table to be quite interesting. These are the past year initiates, right? So the first time people reporting that the first time that they've tried any of these substances was in the past year. And the highest is nicotine vaping. Right, so people are reporting in the past year they first tried nicotine vaping. The second highest is alcohol. And then the third highest is marijuana. So for the past year, for this data set, 5.9 million people over the age of 12 tried vaping. Right? 3.5 million tried marijuana. Okay. And then this is really interesting. This is a past year central nervous system stimulant misuse. And so what they did here is they have different categories, cocaine use and prescription stimulant misuse, but not methamphetamines, prescription stimulant misuse only, cocaine and methamphetamine use and prescription stimulant misuse, prescription stimulant misuse, but not methamphetamines, and methamphetamines, but not cocaine, and then cocaine and meth use, but not prescription, and then methamphetamine use only. And so here, this kind of this Venn diagram, but this black overlap here shows cocaine use as well as methamphetamine use as well as prescription stimulant use. Okay, so we see many of the categories, and then we see the overlap of different usage of the different types of illicit drug use. Questions? Yeah.
How did they collect this data?
Good question. So these data are collected by representative surveys. And so they're asking a representative cross-section of the United States to report their substance use.
By extension, do you think certain categories are really underrepresented because it's a survey?
Yes, probably. And when we're looking at survey data in general, that is definitely one of the limitations, is sampling and then having a representative sample. So there tend to be under reporting among a lot of the diverse groups that don't tend to want to be part of survey research. Survey researchers really do try to sample properly, right, and have a robust response rate. But yeah, absolutely, that is definitely an issue with survey research.
Sorry.
No, don't apologize. Please keep asking.
And then how did they have a method in place to kind of push the people involved to answer honestly when it came to illicit substances, specifically like outside of marijuana, of how would they get someone to admit to it with some of these substances?
Yeah, well, all of these, that's a really good question. All of the data collection is completely confidential and anonymous. But that's also one of the limitations, and one of the biases, we call it response bias, is that people might not want to admit to certain behaviors, right? If they know and they trust that this is completely confidential, no one's gonna know that this was me, and I also, I value research and I understand the importance of being honest, then people will tend to be honest. But that's something that researchers really have to take into account, is that response bias is real. Recall bias is also real. Like, you might be like, well, was that last month or was that the month before? And if we're just asking for the previous month, then that could also affect the results. Really good questions. Yeah.
Is there any socioeconomic correlation with drug consumption?
Generally speaking, yes, right? With regards to the data that I'm showing today, I'm not making any sort of correlations or any causations. But when we really dive deep into substance use, absolutely, we do tend to see substance, and it depends on the substance. But some substances are more, I guess, for lack of a better phrase, prevalent among certain racial and ethnic groups or socio-demographic groups with regards to age, education, and income. And then, so yeah, we do tend to see that. And so when we're designing public health interventions, we really want to be aware of the demographics of users. Really good question. Okay, so this is the overdose death data. So these are overdose deaths by sex, and it shows a pretty steady increase with a few years of decline from 1999, and the most recent data that I have is 2022. It shows the, and again, with regards to all of these data, when we say male, female, we are really recognizing any biases in, you know, the dichotomous category of male and female. But the female line is lower. So female overdose deaths are lower than male overdose deaths in the United States. Question.
Sorry.
No, don't, no more I'm sorry's with questions, okay?
I was just wondering, I was kind of get confused when I see it like by, like across a time frame.
Yep.
Because how are you like taking effect of, is it an overall increase of overdoses of it, or is it, you know, you're seeing that increase because, you know, the population has grown? So how do they do the data to like test whether, oh, this is actually because there's just an increase, more people are exposed to the overdose or drugs, or is it just because we're seeing an increase because there's an increase in
Yeah, no, that's a really good point. The increase in populations are not taken into account in a graph like this, for instance. But we're also, you know, there are actually a lot of factors that should be taken into account, right? Like, reporting deaths as overdoses, right? So we've actually seen, you know, so somebody could have died from an overdose, but it's not reported on a death certificate as an overdose. And it might be reported as, you know, something else, right? That's not taken into account either. But generally speaking, the trend is what we're interested in. And so we're interested in the fact that we are seeing an upward trend, even if population size is a factor. To be quite honest, though, even when it comes to like age demographics, we're seeing decrease in age, like a decrease in the overall population. So the increase in population wouldn't affect the trend that much, if that makes sense.
Yeah.
But that's a really, really good point. Again, I think the trend is what's probably most alarming, but we do have to take into account how the data are reported and what goes into that reporting. We also, yeah,
Sorry.
no,
What happened? What's going on in 2018, 2017, 2018, 2019? That was, I'm trying to think about what was happening in the world at that time.
COVID, not yet,
Like, it would have been 2020, right?
yeah.
That spike.
Yeah,
I wonder why there's a dip, or at least a plateau.
so there's like, there's an increasing trend up until 2018, and then we see a decrease in 2019. Right? That's a really good observation. I'm not sure. What do you all think? I mean, I'm trying to think. I mean, I'm gonna have to look into that, because from a public health standpoint, we could be like, maybe there were better public health programs around overdose, maybe naloxone kits were more popular in that year, I'm not sure. But then we also still see an increase after that, right?
I feel like that's a good ChatGPT question, like what's going on, or what happened in 2017, 18, 19 that in the context of overdose deaths?
Yeah, that's a good, very
It's really
good
clear.
question.
Like just spitballing, I'm more so like asking like. Didn't the administration change from Obama's to Trump's first term around 2018?
So President Obama's last term, so he was 2008 to 2012, and then 2012 to 2016. And then President Trump was 2016 to 20, and then President Biden.
I was considering maybe like changes in policies and like maybe budgets for like.
Yeah, no, that's
For this.
that's a very public health perspective, like public health minded way of thinking about things, because absolutely when administrations change, policies as well as funding around public health tends to also change. Yeah. I like that. Dr. Lynn, can you write that question down though? So that I'll remember to look that up later. Okay. However, one good thing is that now this is provisional data from the CDC. So this is just reported this year. We have actually seen a decrease in overdose deaths. So as I state right here, there's been a nearly 24% decline in drug overdose deaths in the US for the 12-month period ending September 24 compared to the previous year. Okay, which is great. This is really, really good news. And hopefully we'll continue to see that trend. Now, with regards to the types of overdose deaths, we do still see that synthetic opioids, other than methadone, primarily fentanyl, account for the largest percentage or number of opioid, or I'm sorry, overdose deaths in the US. Okay, and this is the most recent data that we have. So, and that's kind of how public health data is, or health data is, right? We wish we could have data from 6 months ago. But the data is reported, this data is reported up until 2022. But again, that provisional data, the CDC was able to report this quick, because this is a huge public health success. Yes.
I mean, I just found it a little bit.
Yeah.
funny about why, and they don't necessarily really know exactly why,
In
but
2018.
yeah, they said, and also like with recent times as well.
Yeah.
Is a lot of like high drug users are now carrying on some. And I think maybe that could be going to the fact where, you know, there's a huge increase of fentanyl deaths.
Yeah.
And so I feel like as somebody.
A big
saw that
awareness,
from my friends, huge
right?
awareness that the
Yes.
drugs that originally weren't, where I could be somewhat safe with them, were now like tiny amount of kill me.
Yeah.
There's more of that educational awareness, so I mean, that's a bad thing that the increased deaths of fentanyl maybe could help, but in some ways, but it says, yeah, like, I was reading, I think in Seattle, it was like 85% of like hard drug users carry it out. Versus back then, it wasn't as a thing. That's,
Yeah. Which again is a huge public health success, right? Huge. Okay, good. So some other promising news. So this comes from researchers at the University of Michigan, who are part of and leading a study called the Monitoring the Future study. And what they have found is that adolescent drug use continues to be on the decline since 2020. And at first they thought that that decline was just because of COVID and people weren't going out and they weren't partying or they weren't, but they've continued to see this decline up until the data collection of last year. So, and what they do is they survey students in 8th grade, 10th grade, and 12th grade. And they have found that the percentage of students who abstain from alcohol, marijuana, or nicotine use this past year, again, steady decline, 67% in 12th grade, and that was abstained, so not doing it. Compared to 53% when they first started collecting this data in 2017, 80% in 10th grade, 90% in 8th grade. So these are, again, promising. You know, and hopefully it really has to do with, you know, better drug awareness and prevention programs at younger ages, which we'll talk about. Okay, so been talking about public health a little bit here and there, kind of interjecting it. What is it? What do you think it is? I know. Public health.
Just going beyond like individualistic health and looking at a population or specific.
Excellent, very good. So population based, not individual. Yes, anyone else? Public health. And even if you don't know the definition, like what's one thing that comes to your mind when you think public health?
Policy.
Policy, good.
Monitoring trends.
Okay, definitely monitoring trends. So in public health, we absolutely monitor data and monitor trends to be able to determine what our public health priorities are. Good. Someone who's not on the public health minor track? Public health, anyone? You can say COVID, because it is.
I guess, implementing intervention programs or assisted programs for based on the trends that you see fit for that
Yes.
region.
Yes, and all of that is really about prevention. Okay, so public health is all of these things: research, health promotion, surveillance, monitoring, communication, disease prevention. But by definition, public health is the science of protecting and improving the health of people and their communities through promoting healthy lifestyles, researching disease and injury prevention. In addition, we detect, we prevent, we respond to infectious diseases. Okay, and that's the definition by the CDC, or the Centers for Disease Control and Prevention. In general, if you only remember one thing today, remember that public health is prevention in populations. Okay, prevention in populations. How do we differ from medicine? We work hand in hand with medicine, but our approach is very different. Okay, and it's not to say that people who aren't, like people who are in the medical field also practice public health, for sure. Anytime you've been to the doctor and they said, you know, you should have this vaccine, or you don't forget to, you know, like sleep well, take your vitamins, cover your mouth when you're sick. All of that is prevention. But in the medical field, clinicians treat diseases and injuries one patient at a time, like you said. In public health, we aim to prevent illness, prevent disease, prevent injury. Researchers in public health and practitioners and educators work with communities, okay, and populations. We work to identify the cause. Okay, so not only are we looking at this data saying, wow, substance use is high, we do try to understand why, so that we can then work with these communities or for these communities or targeting these communities to prevent further illness. Okay, with that said, we will be talking about, again, the substance use approach from a public health standpoint. Now you probably have talked about this quarter, some of the health effects of drug or substance use. Drug use has been associated, I should say substance use has been associated with a lot of different health issues, right? These are just some of them. From cardiovascular conditions to potentially an underlying mechanism or cause for things like domestic violence or other abuse, motor vehicle crashes, homicide. Okay, so this is just a list of health issues that are affected by substance use. Now, when it comes to the leading causes of death in the United States, this is the list. Okay, at the top of that list is cardiovascular disease, followed by cancer, and then unintentional deaths. So these are the 10 leading causes of death in the United States. Okay, anything on here surprise you? No, yes.
I wouldn't say it's a surprise, but it's just like terrible to see that suicides in the top 10.
Yeah.
Super.
And the other thing that I wanted to mention, so if I had more time, we would actually talk about substance abuse and mental health more. There, a lot of the data, so the data for SAMHSA reports both. And there are a lot of interventions that address both simultaneously, also of course separately. But yeah, I just wanted to make that clear too, is that I know the data that I'm sharing is almost one-dimensional in a sense, right? But we do know that it's much more multi-faceted, including the intersection of the relationship with or to mental health. Okay, so these are the leading causes of death. This is what gets written on people's death certificates, right? This is what goes into the registry of the leading causes of illness. I'm sorry, leading causes of death in the United States. But I, in public health, like to think about what we call the leading actual causes of death. So the leading actual causes of death are things like tobacco use, right? Because tobacco use is causally associated with heart disease, for instance. Okay, tobacco use is a causal risk factor for certain types of cancer. Same thing with poor diet and physical inactivity. Now, with that said, I know that there are other sort of issues and social determinants around being physically active and having a nutritious diet, right? It's cheaper to go out and get, you know, something from the McDonald's, although McDonald's is getting more expensive, but the McDonald's, you know, value menu than going and getting fresh fruits and vegetables somewhere, right? So I fully acknowledge that. But poor activity, or poor diet and physical inactivity, I highlighted alcohol consumption, right? That is a leading actual cause of death, but you don't see alcohol consumption actually on a person's death certificate, right? Microbial agents, toxic agents, motor vehicles, firearms, sexual behavior, as well as illicit drug use. These are what we in public health call the actual leading causes of illness. I'm sorry, I keep saying illness, death. Illness and death, but death. Thoughts? Does anything on this list surprise you? Yeah.
It's like the cause of death, like the sexual behavior is that because of like STDs, like HIV, for example.
Correct. Correct. So I'm not saying that like sexual behavior in general is a leading cause of death, but risky sexual behavior.
Because that probably also includes like maternal death. If you're, from all the stuff that comes along with being pregnant and giving birth and how dangerous that is, right?
That's a good point. So maternal deaths are a huge public health issue. That's interesting. I don't know if that would be under sexual behavior. Yeah, but yeah, absolutely. I mean, we definitely count maternal deaths as a huge public health failure, particularly around disparities, because we tend to see it largely in people who have, who don't have the accessible healthcare and things like that. But that's a good question. I'm curious to see if that would fall under sexual behavior. Other thoughts? Yeah.
What sort of things are included under microbial agents and toxic agents?
So toxic agents could be things like air pollution, environmental pollutants, microbial, I said microbial. Things like, what is the word I'm looking for? The certain, so I'm looking for.
Like would include stuff like E. coli and
Yes,
Bacterial.
what is the over, like virulent types of agents that, yes, would cause illness, like E. coli, like salmonella. Yeah. So these again are what we consider kind of the actual causes of death. And what is most alarming about this list is that the actual causes of death account for about 50% of all deaths, but they are preventable. Okay, not necessarily inevitable, right? But definitely preventable. Most of the deaths that we see on the list of actual causes of death are actually premature, meaning without those risk factors, we would not see death. Or we would see death, but at a more prolonged time, if that makes sense. Most of these actual causes of death are caused by individual behaviors, and thus these are targets for public health intervention. Okay, so when we say we're targeting the leading causes of death, we're not necessarily targeting cancer, for instance, but we're targeting activities or actions that would be risk factors for cancer. Okay. All right. So with all that said, with the background on public health, what would be the public health approach to substance use? Dr. Lynn, do you have a thought?
I'm still thinking about it.
Okay.
There's all these trains that are parked.
Okay, well, just throw them out when you have. Okay, what do you think? Yeah,
Reduction.
harm reduction. Good. What do you think that means?
Like in terms of addiction, maybe instead of like making it illegal, you set a program for people that are struggling with addiction, like clinics, stuff like that.
Absolutely. Like the lecture's over. That's pretty, that's like the whole rest of the lecture. No, that's absolutely 100% correct. Good. Were you thinking of something too?
I would say like improving it. Drug use or substance.
Yep, education, good. Anyone else? Yeah,
What the education time to like just public awareness about it, cause I see like signs on the highways saying, don't drink and drive. don't
Yeah.
drink and drive."
absolutely, absolutely. Like those are concerted public health efforts, right? And that's like public health working with Department of Transportation, absolutely, but those are concerted public health efforts. Now, I always wonder though, 'cause I'm like driving and then I'm like trying to read this sign, which is not safe, but yeah.
Mental health resources, especially for, like youth and adolescents.
Yeah. So increased mental health services and programs, particularly for vulnerable populations. Good. So we will talk about the public health approach, particularly to substance abuse, or substance use. And this is, so again, a lot of these slides are pretty wordy, but they're really meant to be, comprehensive, right? So that when I share them with Dr. Lim and Dr. Lim shares them with you, you have this information. One of the keys to a public health approach with regards to substance use is to eliminate stigma. 100%. Eliminate the stigma and any discrimination towards individuals who have substance use disorder. Okay, people aren't going to want to talk about it. People aren't going to want to get help. Institutions, employers, right? Like there are so many moving parts to someone having a substance use disorder and then wanting to get the help. So if we eliminate or destigmatize any substance use, anything around substance use disorders, that helps. And part of that is increasing awareness, right? So increasing awareness about addiction and dependence and trying to make it so that we understand it as a chronic, but also treatable disorder. Okay. So a lot of you talked about education. We also need to potentially implement policies, right? That address substance use disorders as complex And with these policies, again, like, yes, some of the policies around like legalization, but I'm really thinking policies like, you know, you're not gonna lose your job, right? Or policies around, you know, potential, financial support if you have to go to a rehab program. I saw a few hands up, yeah.
I guess I don't wanna go on topic, but it's kind of a bit, so you can stop me. I just was always curious because you know how you see in Europe where there's no stigma regarding drinking and stuff like that, that a lot of younger or just everybody in general has lower like alcohol overdosing, stuff like that, because there's not like a huge stigma regarding it.
Yeah.
But when you compare it to states in the United States where like younger drinking isn't from, like there's no stigma, like some states allow you, if you're an adult, to let your kid drink with you.
Mhm.
There's nothing regarding that. Those don't have decreasing rates, there's actual increased rates of alcohol or consumption, drug usage, stuff like that. So I guess as a public health approach, how do you look at the two and like be able to determine, oh, you get what I'm saying? Like,
Yeah.
that's what I've always kind of
Yeah.
wondered, how you would go about that.
It's a really good question or point or perspective. I'm not sure. I wonder if some of it really is cultural, right? Where a culture, like a European culture, where for generations, it's just been, you know, yes, we drink wine with our meals, and yes, we do this in our family. And it's more of like a widely held cultural belief that might have more of an impact than like a local geographic belief, right? Or trend, or kind of standards. I'm not exactly sure, but that could potentially be it. But that's a really good point, and that's why I think when we design these public health interventions, it really is around like, be safe, right? Like this is what is considered safe. So yeah, really good point though. I without looking at the literature, my first sort of inclination is that, we have again more widespread cultural norms as opposed to norms that might be, sporadic. Yeah. But I mean, you do bring up a good point, right? Like in states where, I mean, I think is Wisconsin one of them where like you can drink at 18 if you're with your, like an adult. But then I don't know, we also see like really big universities in Wisconsin. So it's hard to be able to denote or, really observe any like correlation or any causal factors there.
Yeah, I'm just curious about like, yes, the stigma part about it, like,
Yeah.
oh, it helps in some cases, but also it could increase.
Yeah,
But I guess you're right, it might be.
maybe, yeah. Also, could you put that on the list after that? Because I'm really interested in that. Any other questions or thoughts? Okay, so in addition to eliminating stigma, trying to stigmatize and eliminate or reduce discrimination, another approach is to address substance use disorders as a public health problem instead of a criminal justice problem, right? Offering accessible evidence-based prevention, treatment and recovery, and not criminalizing necessarily drug use. Okay, now it's not to say that there shouldn't be laws and policies around drug use and substance use, right? But we do have a history in this country of criminalizing drug or substance activity as opposed to addressing it as a public health problem. And, you know, one example of that is the war on drugs in the 1990s, right? The war on drugs in the 1990s was a huge failure. And what did it do? It incarcerated people of color more than anything. Okay, so if we take the public health approach of really putting our efforts into accessible, evidence-based prevention, treatment, and recovery options, as opposed to, and even, you know, people who have committed criminal offenses, engaging them in evidence-based treatments. Okay, another approach is to implement evidence-based treatment options for substance use disorders, because research has shown that drug use disorders are in fact treatable, okay, and that people do recover when they're given evidence-based care. Just jumping to this one effective treatment looks at it from a chronic care model, right? So we don't stigmatize people when they have heart disease necessarily. We don't stigmatize people when they have cancer, right? We treat those health conditions as a chronic condition that people generally are sympathetic and compassionate about. If we could treat substance use disorders that same way, we could potentially have more success. And then implementing evidence-based prevention programs means things, oh, what did I? Okay, means things like, I already kind of said that, but addressing what we consider risk and protective factors, and really taking, and I underline this, taking into account things like mental health or social determinants. Okay, I'm looking at the time, so I'm trying to move along a little bit here. But in general, evidence-based approaches for public health around drug and substance use really rely on things like education, regulation, okay, because we do need regulation, and even prohibition, okay? We'll talk about that. What it does not include is punitive or abstinence. Okay, from a public health perspective, we really move away from punitive types of programs, as well as abstinence-only programs. Evidence has shown that abstinence-only programs don't necessarily work. Okay, so let's talk a little bit about what some of these on the left are. So education, with regards to behavior, or with regards to substance use, education, as I state here, informs the public about healthy and unhealthy behaviors. So sharing the negative effects of drug use, recommendations for safe drinking behaviors. A few of you talked about it, increasing awareness around, you know, fentanyl, for instance. You know, and sure, it causes some fear, right? And so people might act a certain way because of fear, but it is really increasing people's awareness about the dangers, right? So that's what we do in public health around education. Effective public health approaches in schools, for instance, really focus on health education in schools. So this, again, might be part of the reason why we are seeing decreases in alcohol, marijuana, and tobacco use among 8th, 10th, and 12th graders, because we're not really doing DARE all that much, right? What we're doing now are health education programs around resilience and grit and self-confidence, right? And self-esteem. Those types of programs really get to the strength and character of youth, as opposed to the punitive, don't do drugs, drugs are bad sort of approach, right? I mean, DARE worked on me, okay, when I was in, you know, that was a long time ago, but I mean, it was actually one of my introduction to public health classes where they were like, Dr. Molina, haven't you seen the trend of like people wearing their bare shirts and then doing drugs? Okay, what also works are things like physician or provider recommendations, okay? Particularly if providers are sharing, recommendations and education in a like compassionate, non-judgmental way, right? That can be really helpful. Advertising, we talked about, the don't drink and drive signs on the highway. Advertising helps. Advertising really, solid public health advertising works, okay? And then there's the social norms approach, right? It really is rooted in kind of like the peer pressure approach, but the social norms approach is when you see positive health behaviors as the norm and you want to participate in that as well. Okay, I don't have any evidence for this, but I really do think that some of so I have a 16-year-old daughter. She thinks smoking is disgusting, right? That is becoming a normative thought, right? Like smoking cigarettes, ew, gross. Whereas before it used to be smoking cigarettes is cool and only sophisticated people do that, right? So part of it is advertising and marketing. A lot of it too is like social norms, right? On the flip side of that, it has become a social norm to vape, right? So on the one hand, ew, smoking cigarettes is bad. Vaping, well, that might be cool, right? So that's definitely a social norm that we want to target to change. Questions or thoughts? Yeah.
I was thinking about kind of circling back to bring up something.
Mhm.
That's where I'm from.
Yeah.
What can you do when it's because drinking culture is so big and it's baked into kind of all of the social norms and how it's in the area. And so I'm trying to think how to phrase this best. And people don't see it as a problem at all, even when they see all of the negative effects. And there are people around you who usually go into downward spirals, right, and cause all sorts of other health issues that they then and do not listen to doctors at all. Because they don't think there's a problem. What can you do when it's so baked into?
It kind of goes back to harm reduction, right? So if we're not gonna change the norm, then we want to reduce the harm. And so public health prevention happens on a primary, secondary, and tertiary level. So primary prevention is we just prevent it from happening at all, right? Secondary prevention is, okay, it's happening. We want to prevent it from getting worse, okay? And then tertiary prevention is like, well, it's happening, it's happened, it's bad. We want to prevent the ultimate, like we want to prevent death, right? And so that's where the harm reduction comes in. So we're not going to say don't drink, because the culture around drinking is so strong and the norms are so strong. But we are going to say, like, we're really going to push for, designating a driver, right? We're really going to push for on days like, like 4th of July or, New Year's Eve, trying to partner with Uber and Lyft to offer free or reduced, rides, right? Like those sorts of actions, because we probably can't eliminate the behavior completely because it's so embedded in the cultural norm, but we can try to reduce the potential harm, right? That would be the public health approach for a situation like that. Okay, regulation, it's controversial, right? It has been controversial since the days of regulating alcohol, right? Back in the early, whatever it is, like the early 1900s. But it is warranted when its intent is to refrain people from being harmed, okay? Either harming themselves or harming others. And so some public health laws exist around things like, violent crimes, traffic regulations, for instance, right? Those are there to keep people safe. Even restrictions on alcohol, drugs, and tobacco. So in the state of Illinois, we raised the legal age to purchase tobacco to 21. And that was a regulation that I say we, like I did it. I didn't. But that was a regulation that public health practitioners and policymakers really felt could reduce the age at which youth started smoking. Okay, so again, regulation. And then prohibition. You know, that was what I was talking about, 18th Amendment. Okay, so prohibition against drugs such as heroin and cocaine, that sort of prohibition is generally accepted, right? Like hard illicit drug use. But again, the regulation and the prohibition from a public health standpoint has, you know, there's some debate around. Okay, all right. So this is a video. I'm not going to show it again in the interest of time. If we have time, I will later. But one prohibition that I mentioned this earlier that did not work was this war on drugs. So the war on drugs was in the 1980s under the Reagan administration. It was not considered an effective public health approach. It was super, super expensive. Okay. It incarcerated substance users, drug users for minor offenses, which disproportionately targeted people based on their race, ethnicity, and income. Okay, and it really was this is our war on drugs. We're going to stop people from using drugs, all people. And instead, what it did was, like I said, incarcerated disproportionately higher rates of men, particularly Black and brown men, particularly Black and brown men who were poor, and it did not have any effect on drug use. Okay, so this sort of prohibition, these types of models don't work from a public health standpoint. Okay, what does work? Harm reduction. Okay, harm reduction is a strategy that's directed towards individuals or groups. Okay, so it could be like from a large scale public health campaign or individuals to reduce harms associated with certain behaviors. Okay, Taylor all describes it as reducing the negative effects of health behaviors without necessarily extinguishing the problematic health behavior completely or permanently. Okay, so we're not trying to say people can't do drugs, but we're saying things like, if you're going to use substances, let's figure out ways to reduce the harm associated with it, particularly overdoses, in safe ways. Okay, and we'll talk about what those mean. When we apply a harm reduction approach to substance use, that actually accepts that there is some level of substance use, both illicit and non-illicit in society, that identifies or addresses that there is a problem, okay? Or that it is inevitable, but again, our main goal is not to necessarily eliminate the problem completely. Although what we have found is when we implement harm reduction programs around substance use does tend to decrease. Okay, so that has been a welcome sort of side effect or outcome. When we define the goals and objectives, so in a harm reduction model, we define the goals and objectives as reducing the adverse consequences, again, not necessarily eliminating the behavior. So the emphasis really is on health and social economic outcomes, not necessarily the actual drug consumption. So the history of harm reduction, it was first developed in the 80s in opposition to these abstinence-only programs. Initially, it was used and found to be successful in addressing substance use or abuse with adults, and it has increasingly been used for youth substance use. So how do I play the video? This is a video. Yeah.
might work.
But there's no, I swear. If we can download this video. It's okay. I'll share the slides and then you can watch the video. But essentially, it's like this, like, kind of cute little video of like what is, right? But I'll talk about what it is. So harm reduction strategies are about education, really focused on education, really focused on awareness, including information and resources on safer ways to use substances. Harm reduction strategies also incorporate outreach and support groups. So it's not like we're gonna just try to reduce your harm. We are gonna try to reduce your harm while also simultaneously providing you with resources and support, okay? So some of the harm reduction strategies include things like supply distribution, needle recovery and exchange programs. Some other harm reduction strategies for opioid use, so using opioid substitution and should say and cannabis therapies. Take home, I think we talked about this a little bit earlier, but take home naloxone kits. That has been shown to be an effective and successful harm reduction activity, and then supervised consumption or injection sites. And we'll talk a little bit more about this, okay? One such program here in the city of Chicago is called the Chicago Recovery Alliance. They mostly perform outreach using their van, right? And so you can actually go on their website and see where the van is going to be, or vans are going to be. But some of the services include, again, providing injection equipment, so safe needles. One of the risks, particularly around the spread of infectious diseases like HIV and hepatitis C, are the use of unclean needles. So needle exchange, providing safe equipment. Like we said, naloxone, having sometimes, like you had said, people are able to get it and have it with them. Other times, the Chicago Recovery Alliance could potentially administer it, right, in an emergency situation. They also provide overdose training, which is really, really important with regards to education. They have safer drug use training as well. So really training individuals on how to carry out substance use in safe ways. They also have counseling. So the harm reduction counseling that I talked about when it comes to providing support and guidance. They have referrals, so they're also able to refer people to different programs. They have materials on safe smoking as well as safe snorting. They collaborate for with the Alliance for Collaborative Drug Checking. Okay, so they can have things like fentanyl strips to ensure that the substances that people are using are free of fentanyl and clean. They have HIV testing, hepatitis C virus testing, and then they also have linkages to care for those infectious diseases, and then they offer safer sex supplies, right? Particularly around contraception. Questions? So this is one example of harm reduction, public health in action here in the city of Chicago. We used to have things like safe injections, like stand alone sites. A lot of those types of harm reduction reduction programs are getting cut because of funding, but, you know, resources like the Chicago Recovery Alliance are literally out there saving lives. What do you think? What are your thoughts? Yeah.
Seems to me that, harm reduction is, like, even as an undergraduate, I can see that this is like a lot better than prohibition.
Yeah.
Why do you think that policy is still, it was like for weed, it's still like illegal, you know, nationwide? And like other drugs, why do you think that is? So just taking the harm reduction approach.
Like many things, like many topics or issues in public health, they're political and politicized. I think I personally think people have a lack of education and awareness around something like harm reduction. I think it also is because people think this, right? So they think like, well, if we're giving people drug paraphernalia, isn't that just going to increase or encourage risky behavior? And the answer is actually no, right? But people still think, unfortunately. And that's why things like abstinence only, even around, you know, sexual behavior, like that is still really prevalent in schools because they're like, no, if we talk about it, then people are gonna be like, oh, okay, well, now I'm gonna do it, right? And that's not the case, but this is what unfortunately, a lot of people still believe, right? And so that's where there's the debate around it. That's also why we need people who are going to be vocal and fight and try to change policy, right? And try to say, well, look at this data and do research and say, no, look at the outcomes of these harm reduction programs, right? But you'll still have people that can't, if we go back to some of the public health strategies, they can't destigmatize substance use, right? If they're not destigmatizing substance use and addressing discrimination, then they can't get to this point where they feel and believe that harm reduction, you know, is a viable option. Yeah.
Yeah, how would you encourage schools to better educate while still respecting the opinion?
Oh, that's such a hard question to answer. So, excuse me, there are like state regulations and laws around curriculum. So it depends on where you're living. It also depends on your district, right? So I'm actually an elected board member for a district out in the southwest suburbs. And one of the topics of discussion among all districts in the state of Illinois was whether or not we would have a unified curriculum around sexual health. And people voted no, because they felt that it wasn't the state's place to tell individual districts how they should teach sexual health, for instance, right? That's just one example. So those are some of the like political challenges around being able to say, hey, like, let's take on like a more like education and awareness approach versus an abstinence only approach, right? In the district where I am, we do take on the approach that I mentioned earlier of grit and integrity and strength and confidence, right? But not all districts are going to do that. So part of what I encourage you all is, you know, and it's going to sound kind of kooky, but really like vote in your local elections, right? Because you want people on school boards and, you know, in local elected roles who are going to potentially have the perspective that you value, right? So that's just one sort of like vote, right? Like somebody as I was running for my election, somebody could ask me, what are your thoughts on this? You know, and I actually had people asking me questions like, what are your thoughts on this? What are your thoughts on that? So make your vote count. But yeah, to kind of like talk about, you know, how are decisions made like at a like local school level, state, right? So there are like state benchmarks, so to speak. But then a lot of it is decided at the local. Okay, so no, the answer is no, not necessarily. If the outcome is to reduce morbidity and mortality, illness and death related to drug and substance use, then harm reduction models are actually successful. Studies show that harm reduction models actually contribute to a decrease in deaths and decrease in overdoses from drug use. Harm reduction models have been effective in decreasing HIV transmission among IV drug users, and when coupled with education and outreach services, harm reduction strategies have led to increased drug treatment program entry. Okay, so people who are part of harm reduction programs actually seek out help for drug addiction. Okay, so it's the opposite of, well, if we're promoting this risky behavior, then people are just going to do it. And we're going to have bad outcomes. Okay, some other evidence, again, in the interest of time. And this is, again, evidence. These are studies that are showing that harm reduction models work. All right, so in our last couple of minutes here, I have a couple discussion topics. You tell me which one we want to talk about in the last 3 minutes, or if you have questions, we can just open it up for questions. But to what extent do you think people choose their own health? What are some ways in which health is affected by factors not of one's choosing? Or what did you learn about health-related behaviors in school? And do you think health education classes were effective in influencing your behaviors? 1 or 2? 2? 2. Thoughts? Tell me. Oh, you wanted to do 1. Sorry. Well, okay, raise your hands. Who wants to do 1? Who wants to do 2? Who wants to leave? Just kidding. Okay, we're doing great. What did you learn back in school? Think about it. Yeah.
I just remember like my middle school health class was like one of the only things for middle school that's not a blur. It like really ingrained like cigarettes, for example. Like
Okay.
I remember being like so like, oh my god, I'm never gonna touch a cigarette from like what they showed us.
Do they show you like a
Like
long?
lungs,
Yeah. And that's not like, I mean, that's kind of scary. So mine was
yeah.
like, this is your brain on drugs. Do you remember that? Like, and they would crack an egg on a frying pan, and that stuck with me to this day.
Yeah.
So like, it's both. It's kind of meant to scare you, but also bring awareness. So you're like, I'm not smoking because I saw the news. Good. Anyone else? What do you remember? Yeah.
I mean, my middle school health experience was just watching the film Super Size Me and never eating a Collins fan.
Interesting.
But there was not much about like drug. They just said, don't do drugs, don't drink, and that was it. They sent us on a thing.
Yeah, but they were like, also watch Super Size Me. Yeah, and I do that worked for you.
That was disgusting.
So you've never had a go with it.
I haven't really touched it
Yeah.
unless it's like an emergency.
Yeah.
This is not about substance use, but just like health.
Yeah.
I feel like there should be more sex ed in like college compared to high school. Cause at least in my high school, like no one really took it serious because it was like, oh, ew.
Yeah.
And there was still like such a stigma, I guess you could say, around it.
Yeah.
And I feel like I still know so many people my age that like don't really know what an STD means.
Yeah.
Like, so I feel like that should be more like college compared
Good point.
to high school.
I mean, it's hard if you also think about it our institution is a Catholic institution.
Yeah.
So but that is a really good, yes.
Yeah, trying to go off that, I think the most effectiveness thing would be the age of things, because if I'm showing the cigarettes when I'm like, in elementary, middle school, of course I'm gonna be like, ew, gross, I'm never gonna do it, because I'm not exposed to it. Versus when you do a food that primarily, is exposed to that, so like high school or college, then I think that's when you could be more effective in talking about it and, assessing it.
Right, well, and I totally agree with that, and then even things like vaping, for instance, so I don't know if you just saw, but last week there were just these studies, and I know we're at time. That showed, the increase in popcorn lung among youth who vape, right? Those are the things, and that is irreversible, right? Those are the things that we need to build awareness around, right? That are timely and age appropriate. Okay, thank you all so very much. Reach out to me if you have any questions. I will share the slides with Dr. Lim, and thank you for your engagement and your interest. Please stand by.
Thank you so much.
Yay.
That question, Stephen.
Okay, thank you. I should have something to.
I always leave the lectures with like more questions than anything else. So.
I always love coming to